I am Joan Esther, a midwife from South Sudan, working for MSF South Sudan. And currently I am working in pediatric department. So I am going to present a case of severe malaria with a multi-system organ dysfunction. This presentation is going to be focusing on presenting complaint of the conditions or the disease, case of present illness, past medical history, family and social history, clinical manifestation of the disease, clinical examination, review of systems, pathogenesis of the condition, laboratory investigation, clinical management, nursing interventions, and complications. So this morning at 9:30 a.m., we received a 4-year-old male child residing in Malakal village of South Sudan, malaria endemic region, that is to say the area, brought to MSF supported healthy facility by his mother. Immediately after receiving this patient in the triads, pediatric triads, because the person was sick or ill-looking, immediately the nurse on duty and the clinical officer admitted the client in pediatric. Immediately information reached to the pediatric doctor to come and review the patient. Now we are going to look at the presenting complaint. The caretaker reported that the child developed high-grade fever for 5 days, inability to feed for at least 2 days. Then there were 3 episodes of generalized tonic-clonic convulsions within the last 24 hours. And the child passed a very dark urine, looked like Coca-Cola. This is according to the mother during the consultation. Presenting illness. The illness began 5 days ago with a sudden onset of high fever, vomiting. The caregiver said she tried to manage the fever with oral paracetamol, of which never helped or does no improvement. Over the past 24 hours, the child became completely unresponsive, suffered multiple seizures without full recovery of consciousness between episodes. Even the child reported that stopped tolerating or taking any oral soft or food completely. Then we are going to see medical or past medical history. According to the mother's report, no history of chronic illness such as sickle cell anemia, epilepsy, congenital heart disease, no prior admissions for severe malaria, though the child had two uncomplicated episodes of malaria in the first year, and it was successfully treated with the oral antimeter lumefantrine. It's also important to look at the surgical history. No any trauma or surgery incidents been reported. At the allergy site, no known drugs allergy or food or environmental agents. It also is very good to look at birth and developmental history. Antenatally, the mother said she attended full antenatal services in the last pregnancy. And she gave birth to this baby in the full term, of which 42 weeks, according to the mother, by spontaneous delivery being obtained at the local health center. No antenatal complications reported by the mother, and the birth weight of this baby was 2.8 kilograms, of which it was a normal body weight. Neonatal period, no history of neonatal jaundice, prolonged birth asphyxia, neonatal sepsis being reported by the mother. It's also good to look at the developmental state of this child. A child achieves all age-appropriate developmental milestones, such as gross motor, fine motor, language motor, so on time. Even currently, the mother said the baby could speak a full sentence and runs without any assistance by anyone. We are going to see nutritional and immunization status. Regarding nutrition, the child benefited on exclusive breastfeeding for 6 months, followed by supplementary feeding with the family food such as millet porridge, beans, veggies, and no sign of acute malnutrition period to this illness. Even the current body weight is 15 kilograms, of which this body weight suits within the normal ranges according to the World Health Organization. Weight for age and growth chart for a year-old baby. It's also good to see immunization status of the child. Child was fully vaccinated according to the mother, and this is done according to the National Expanded Program on Immunization schedule. These vaccines include BCG, polio, diphtheria, pneumococcal, even including the measles vaccines at 9 months of age. Then, family and social history is also very important in this presentation. A child lives with both parents, 2 older siblings of their age 7 and 9 years, where they were staying in a house with the congregated iron roof, according to the mother. And the family lives near a swampy area with stagnant water, which is a risk to the mosquito breeding. And then we have to see a malaria prevention. The family that owns a long-lasting insecticidal nets. However, the mother reported that the patient frequently slept without a net during the first month due to the high indoor temperature. Though the 2 siblings are currently healthy with no any active fever. Then, good to see socio-economic status of this client. Parents are small-scale retailers within the local market, and the family gets a clean drinking water from a communal borehole. After looking at this history, we are going to see clinical signs and symptoms of these conditions. High grade fever or hyperexia. This is of auxiliary temperature being taken 39.2 degrees Celsius. These fevers contributing to the increased metabolic demand and lower seizure thresholds. Severe tachycardia. This been as evidence of 140 beats per minute. This pulse rate increase because it is an active physiological effort to keep the cardiac output stable, despite severe anemia and blood loss, or else the volume lost. One of another clinical signs tachyphonia. This been indicated by 45 breaths per minute because this child breathes rapidly and deeply without pulmonary obstructions. This is to clear a volatile acids out of the bloodstreams. These are the major clinical signs and the symptoms. We are also going to continue and look at the clinical examination of this child. Generally, a child looks so critically ill, lethargic, deeply jaundiced. Then, in this neurological examination, of which blood type coma score been used to assess this person, of which obtained 2 out of 5. And localized response to pain, abnormal vocalization, and the baby also obtained a neck stiffness during the examination. Then we are going to examine respiratory system. There was a presence of tachyphonia, of which 48 breaths per minute with a deep acidotic breathing. This is to clear, and there was a clear lung on auscultation. Then we also examine the cardiovascular system. Tachycardia, the heart rate of 140 beats per minute, and even there was a delayed capillary return over 3 seconds, including whole extremities of the lower limbs. This indicating a shock in this client. Now we are going to look at the review of system. Then the first system we are going to see is the central nervous system, or an level of consciousness of the child. This is being evaluated using, or evaluations been applied in pediatric using this blood type coma scale, of which is the standards being used in pediatric. So this child obtained 2 out of 5. Eye response, eye movement response has been scored 0 out of 1, because the child could not direct or track eyes towards sound or visual stimuli. Vocal response been obtained 1 out of 2. The child inappropriately emits and even obtain a weak cry when a painful stimulus been applied. Motor response 1 out of 1. The child could withdraw limbs away from a painful stimulus, and the child could not locate exactly where the pain comes from. The pupils echo round and reactive to light bilaterally. This tells clinicians that the brainstem is still intact, and intracranial pressure has not yet caused a fetal herniation. Look at the reflexes. The child has a generalized hypotonia, which means that's to say fluffy muscles, and these have been assessed by using a brick deep tendon, which reflexes 3+, with the bilateral upwards extensor plantar response, of which this is a common sign of recent status epilepticus or emergent epilepsy. Cardiovascular system, capillary refills been prolonged for over 3 seconds with pulse and hands and the feet are noticeably cold to touch. Respiratory system. On inspection, the baby breathes deeply, rhythmic, and there are no signs of air passes blockage such as subcostal recession, intercostal retractions, or nasal flaring. On auscultation, there was a vascular breath sound bilaterally. The lung and the chest are clear. No crepitation, no oozing. This directly isolates the tachypnea as a metabolic issue in this case, rather than respiratory infection like pneumonia. Then gastrointestinal and abdominal examination. On inspection, the abdomen appeared flat, moves symmetrically with the respiration. No dilated veins are visible. Palpation. The abdomen soft. There was a slight tenderness at the right side with the palpable mass below the right costal margin. And at the left side, there also a mild palpable mass below the left costal margin, of which this could suspect or could detect a hepatosplenomegaly in this person. And this enlargement of the spleen that could be caused by the heavy load of filtering out destroyed red blood cells and capturing mechanical destruction of parasites. Now, as we said on the mucosas or mucocutaneous assessment, the sclera and the mucous membranes. The mucous membranes appear pallor and conjunctiva. The sclera looks so yellow. This display that this yellowness can indicate a jaundice in the child, and it can also indicate that or can reflect that a high circulating bilirubin level from the broken red blood cells. This skin turgor or skin return took 2 seconds to return to its state, confirming this a significant dehydration from the child. And this could be contributed by vomiting, poor intake of the food or fluid. Now, we are going to look at this pathogenesis of this condition. When the Plasmodium parasite enters the bloodstream via a mosquito bite, usually it targets and invades healthy red blood cells, that is to say the erythrocytes. This is for the parasite to survive and replicate. As the parasites develop inside the cells, from the early stage, it forms a ring into the more mature trophozoites and schizoid. It radically alters the structure of the host red blood cells or the client red blood cells. The parasites digest the cell's hemoglobin to feed itself, leaving behind a toxic crystallis. More critically, the parasite remodels the surface membranes of the red blood cells, producing tent and stick knot. Now, we are going to see these steps. The first step is cytoadherence and mechanical destruction. Once this Plasmodium falciparum plasmodium parasites matured into the trophocytes and the schizoids inside the red blood cells. It expresses a sticky surface protein, that's to say Plasmodium falciparum erythrocytes membranes protein 1. This protein acts as a molecular, causing the infected red blood cells to stick to the endothelial lining of the small blood vessels, and to also other non-infected red blood cells. Parasite by sticking to the vessels or vessels wall, the parasites avoid being swept into the spleen, where they will be destroyed. However, this causes massive logjams in the capillaries, blocking normal blood flow and depriving a vital organ of oxygen, of which resulting in tissue hypoxia. Step 2, accelerated chemolysis. How does this chemolysis happen? About the red blood cells destruction. Intravascular. As the parasites replicate inside the red blood cells, they laterally burst the red blood cells open to release a new merocytes into the bloodstream, of which going to form this extravascular. The spleens recognize that the surviving red blood cells have become rigid and deformed due to the infections. The splenic microphages work overtime or work very hard to destroy both infected and healthy standby red blood cells in massive quantity, cascades into the target organ like kidney. Yes. Now the sudden explosions of the red blood cells floods the plasma with the toxic amount of the free hemoglobin. The kidney filters these debris or parasites, but the high concentration of the free hemoglobin causes oxidative stress, forms obstructing cars in the central tube, in the renal tube, and cut off local blood supply, of which it trigger acute tubular necrosis. Now we are going to see the liver, how the liver got damaged. The breakdown of the hemoglobin releases massive amount of unconjugated bilirubin. The liver's processing pathways are completely overwhelmed, causing bilirubin to back up into the tissue. Now we are going to look at the laboratory investigation. Rapid diagnostic tests for malaria done positive. Positive Plasmodium falciparum been confirmed positive, which means this one is confirming a malaria etiology. Blood smear for parasites also been done. This one is to measure the parasite, the level of the parasites in the blood, of which confirm 4+, hyperesthemia. And this one confirming that the child has a high parasite lot. Complete blood count also been performed. Hemoglobin 4.2 gram per deciliter. This confirms severe infection or severe anemia, of which is a life-threatening. Platelets count, of which 4,500 liter. This indicating thrombocytopenia because of this destruction of the red blood cells. Urinalysis, and this have been done microscopy. Dark 2-3+. No red blood cells on the microscopic film. This one to confirm hemoglobinuria or hemolysis rather than to urea. Then serum creatinine and urea been done. These results indicated slightly elevated creatinine, 140 unit millimole per liter. This indicating acute kidney injury. Random blood sugar 1.8 millimole per liter. These results also indicate hypoglycemia, of which is a common metabolic complication of severe malaria. Yes, and another test is serum total bilirubin, 68 unit millimole per liter, or 3.9 milligram per deciliter, indicating or significantly indicating hepatic dysfunction and intense hemolysis. Anterior blood gas and blood latex, pH 7.2, carbon dioxide 11 millimole per liter, latex 6.2 millimole per liter, indicating severe metabolic acidosis, lactic acidosis, or severe hyperlactemia. Blood grouping, this baby having O positives. Not only that, we also going to look the ultrasound services done on this child. Liver slightly enlarged, 18.9 centimeter. This one indicating hepatomegaly. Spleen also slightly increased in size, not 16 but 15.7 centimeter, indicating splenomegaly. Immediate clinical management of this case. As I said, this person's been admitted in pediatric. Oxygen therapy was put already. This person, it was 2 liters. This person was already stabilized with the IV lines. Then this is where hypoglycemia correction is being done with the 75 mils of 10% dextrose intravenously. And maintenance dose are being given, yes, in the child. This one is to silence the drop in the blood sugar. Even anti-malaria therapies also been prescribed and given. Always, this is the high dose. That's also pediatric, 3.0 milligram per body weight. In total, the child received 45 milligram in first hours, 12 hourly for 24 hours. Then continue with the same dose 24 hourly until the child could tolerate oral therapy. Seizure control being done by administration of diazepam, 4.5 milligrams given slowly. This is to control or arrest the active convulsion in the child. Blood transfusion is also being commenced. 300 mils of whole blood, of which is given slowly over for 4 hours. But before this administration, it was a furosemide. 2 milligrams was given before that. This one is to mitigate circulatory fluid overload of the child. Then ceftriaxone intravenously also been prescribed and given 80 milligram per body weight. In total, 1,200. This is to ensure optimum tissue and blood-brain barrier penetration because of this severe infection. This is given because the severe malaria infection temporarily compromised the child immune system, especially depressing microphages functions and the ability to clear bacterial pathogens from the bloodstream, so leaving the child highly vulnerable to opportunistic bacterial infection like meningitis or bacterial meningitis infection. Not only that, even normal saline of 0.9% have been given. In total 15, not 15 but 50 males are given intravenously over 16 minutes. This is to resuscitate this baby from the shock. Then we are going to see the nursing interventions. What are they? Strict fluids balance monitoring. This been monitored closely and well documented in the fluids monitoring charts. And even been balanced also to look at the fluids output hourly. This is to target or to get minimum of 1.5 mils per body weight per hour, because the patient has leakage capillary and the renal failure. And fluids are well managed on a strict and knife edge to prevent pulmonary edema. Neurological care and air safety. The child being put in a left lateral position or recovery position. This is to safeguard the airway from aspiration. The baby was being turned every 2 hours to prevent pressure injury of bed sores. Frequent bed glucose monitoring or screening. Checking capillary blood glucose every 2 hours, because severe malaria blocks hepatic glycogen synthesis. And even atosinates can stimulate insulin's release, making this person highly vulnerable to asymptomatic hypoglycemia. Terminal regulation. Hyperexia have been well managed using a paracetamol injection. Even gentle tape sponging have been applied, that's to say the lukewarm water, because a severing increases metabolic oxygen consumption and can lower seizure threat to leave this person vulnerable. Even drugs administration or drugs that are prescribed are well administered according to their time, according to their doses. Even the blood's been also been transfused, and during the transfusion, these vital signs have been closely monitored. Vital signs like oxygen saturation, temperature, respirations, pulse rate. These have been monitored every hours or hourly for the first 4 hours to detect any deteriorating conditions or hypersensitivity reaction to these drugs. The hypersensitivity reaction to the drugs and blood products, of which sometimes is becoming life-threatening. Now we are going to look at the complications or the risk complication. Yes, one of these complications is cerebral malaria, because this baby has already having dizzy convulsions, the tonic state. So the homa and the reasons generalized seizures resulting from microvascular cirrhosis, localized hypoxia, and increased intracranial pressure in the brain capillary. Severe malaria anemia. This is one of the risks. The drop in the red blood cells must due to the rapid chemolysis and splenic clearance. And then another complication is the acute kidney injury. Yes, the tubular intestinal damage and acute tubular necrosis caused by the massive burden of filtered free hemoglobin, coupled with poor renal perfusion, because the baby already having issues with the oxygen circulation. Another complication is severe lactic acidosis. Systemic metabolic acidosis secondary to the tissue hypoxia and anaerobic glycolysis. Now, not only that, those are the risk complications, and we are going to see a potential complications. In case this person is not well managed, what is going to happen? Acute respiratory distress syndrome may happen, because this high risk of involving non-cardiogenic pulmonary edema if endothelial capillary leakage worsens, or if the fluid resuscitation is not well managed and it is too aggressive. Now we are going to conclude, or conclusively, urgent metabolic stabilization of this person by giving or by correcting a hypoglycemia with 75 ml of 10% dextro intravenously, and severe anemia with the 300 ml whole blood transfusions takes priority, as the metabolic threats can cause rapid death in this child before antimalarial drugs takes its effect. A child should receive the high dose of pediatric atosinate IV or intravenously, of which 3.0 mg per body weight, rather than the normal dose for adult of 2.9 mg per body weight. This is to ensure rapid parasicidal actions clearance. Giving these drugs is able to clear the parasites. Yes. Vigilance nursing care. Surviving or survival of these clients depends heavily on balancing on a strict fluids management, because his kidneys are compromised and his capillaries are leaky. Fluids intake and output must be tracked to prevent the development of petropadiatritis or the fluid overload in the lung. Thank you. This is the end of my presentation. Any question, additional clarification is mostly welcome.